Hi, everyone. We've all been to our doctor's office and been handed this data capture device, a relic from the 18th century, quill and parchment. It was using this device and the frustration of it that led me to start Seamless Medical Systems. So I'm going to introduce you to the 21st century. This is our Seamless Patient Engagement Platform. I won't get into a lot of detail, but it starts at the pre-visit, and we engage patients and take them through point of care, registration on the iPad, and then communications afterwards. I'm one of those people that came from digital media and marketing, but I came to start the company because I'm a consumer of healthcare services. And you notice I didn't say patient. So the patient or the consumer walks into the clinic, they're handed an iPad instead of this thing, and they fill it out. So I'll take you through it real quick. We've designed our platform for a computer illiterate 75-year-old. So I wanted to make sure my mother-in-law could use it, and she can. So a patient simply walks in, they enter their information, and I'm going to be very specific here. That is my birthday. And we do away with paper, printing, scanning, shredding, and data entry. It's todo en español también. We can support multiple languages. And patient moves forward. Why are they here today? Have a cold. Reason for visit. Now we're a cloud-based system. We're connecting to the EMR. We're connected to half a dozen EMR and PM systems there. You see my address was pulled up, so there's no more of that frustrating. I filled that out 3 months ago. Why do I have to do it again? Nothing's changed. We have all kinds of custom forms. We've got standard form sets that patients can use. We can screen for lifestyle. We've got family, social, medical history, review of systems. All the consent forms. We're putting in video consents now for procedures so a patient can see what a spinal tap looks like. Maybe they don't want to see that. But patient signs with a fingertip. That's it. Registration's complete. We displaced a kiosk system at a national clinic, Target Clinics, because it was taking 10 to 12 minutes for a patient to check in. Our average check-in time is 2.5 minutes. Now we serve up a magazine called My Health. That's a patient education platform and a practice marketing platform as well at the point of care. And we target all the content based on the name, age, gender, and reason for visit for that patient. And we pull content from National Institutes of Health and, oops, this cable came out. There we go. And CDC and Mayo Clinic. This is an example of a marketing page for a health system. And patients are spending on average 7.5 minutes with the magazine, up to 12 minutes. And in fact, some of our customers are buying more iPads because the patients don't want to give it up after they register. How much time we have? That's basically our platform. We have lots of interactive capabilities on there. And it's great to be here. Thank you.
Okay, so my quick question for David is just, I think we'd love to hear a little bit about what the customer experience has been so far using the Seamless Medical platform.
Yeah, thanks. We're installed in 125 clinical locations in 17 states. We started about 1.5 years ago in terms of installation. We ran surveys with our patients using it in clinics. We have a 99% patient satisfaction rating from all the patients using it. We have a 9.7 net promoter score of the staff that's using it in the clinics. So we're at the Target Clinics nationwide. We're at Houston Methodist Hospital. Rite Aids, Ready clinics, and we're growing like a weed. And I'm very pleased to say that California Healthcare Foundation is an investor in the company as well. So thank you very much.
I just want to introduce Rebecca Coelius. She's the Director of Health at Code for America, and she's just going to walk us through a presentation of the work that she's doing.
Hi, and thanks for sticking with us. So I'm going to walk you through more of an approach to building technology that we believe has a very significant impact on health outcomes. There's some demos embedded, but slightly different than a demo. So I work at Code for America. It's a nonprofit that partners with local governments across the country, so city, county, state government. And together we build new digital services using technology, but just as importantly, bringing together people from the community and in government to apply practices like user-centered design, lots of other approaches that we're used to in the rest of the technology realm, but is often pretty deficient when it comes to government technology. So probably a lot of people here in this room remember when banks used to work and look a lot like this. Thankfully, that's no longer the status quo, and it now looks and works a lot more like this. That is not the case for government and many of the services that government provides, from healthcare services to social services, and in the case of this photo, the DMV. Why is this still how we interact with government and government services? Over 90% of Americans have access to a smartphone or own a smartphone. 2/3 are on Facebook. 1/3 has a tablet. And even in the communities that many of us care about in this room still have a feature phone, a smartphone, and for many of them, that's actually the primary way that they access the internet. They don't have access to a desktop computer or a laptop. So lots of opportunities to reach people in new ways using technology. We're all very familiar with this. This is one of the most public sort of technology disasters that government has ever dealt with. Thankfully, because it was such a disaster, it was a national emergency, a dream team was quickly put together, and now the federal marketplaces are back on the right track. The thing is that healthcare.gov is happening everywhere across the country every day for all sorts of services, healthcare related and social services related, that don't impact the middle class, people who are already digitally savvy, but are impacting some pretty disempowered communities, often those that have some of the worst health status in our community. One of those that we're working really hard on at Code for America is the food stamp program across the country. In California alone, about 1.5 million people are eligible for food assistance, the SNAP program, colloquially known as food stamps, and they're not getting it. They're not getting it for lots of reasons. We really believe what should be an emergency, a national emergency at the level of healthcare.gov, has become the status quo within food stamps and a lot of other social services. As an example of that, this is some data that our team at Code for America has collected. We've been measuring the uptime of websites across the country that provide vital information and an online application to sign up for food stamps. This data collected by us, caveat, it's messy, but it's definitely been independently validated that for a lot of these states, the website is regularly not up, not running, not available after work, on weekends. It's not just a problem for people who are trying to apply, it's a problem for the assisters that are often paid and charged by government and by local nonprofits to help people apply. Many of those that we work with here in San Francisco will actually receive an email maybe a couple hours after an outage has started, a planned outage has started, and they're not given any information on when the website will be back up and running. So you just can't help people. And this has actually happened in the middle of these massive outreach events they spent a bunch of money organizing. And it's just a massive waste of people's time. This is the wonderful experience that you would have if you went to apply for food stamps in the state of California currently. There's 3 major systems. This is one of the largest of them. I could stand here for 10 minutes, and you still wouldn't be through the entire thing. It's at least 50 screens long for the average applicant and takes at least an hour to complete. And there's lots of other issues that arise when you're trying to apply even after you get past submitting the application. About 13% of people fall off at the interview stage because it's so difficult to schedule an interview and actually conduct the interview. About 3.8% withdraw afterwards. In our follow-up information, it looks like it's because people are just getting wrong information when they're reaching out to people who should have better policy information. Another 11.45% are dropping off because they just can't submit their verification documents. Believe it or not, often people have to go and stand in a line with a piece of paper to show that they actually are at a certain income level, live in a certain place. And altogether, there's far more people falling out of the application process because of relatively silly points of friction than there are people that are falling out because they're truly not eligible. Our team likes to call this the onion of friction, and just like an onion, it kind of makes you want to cry when you start peeling back the layers. So at Code for America, we are partnering with the state of California, local governments, the city and county of San Francisco, Marin County, Contra Costa County, and the amazing food banks and other nonprofits in those counties to find a better way to help people enroll in food stamps and then use the program once they're on it. This is a little bit of an intro to the current tool that we've built called Clean Assist. Much easier to use. You can upload your verification documents, and altogether it takes around 20 minutes to complete. And we have very, very happy users using it in all 3 of those counties at this point. Another product that we've developed called EBT Near Me. This is a web app that's optimized for mobile phones, because again, many people within this population we're trying to reach are only accessing the internet through their mobile phone. This shows locations where you can use your EBT card, which is the card that food stamps are attached to. And it also helps you find ATMs with really low surcharge fees, because we found that people in California in particular, a lot of the financial programs where you can actually take out money are attached to an EBT card. And California alone is spending about $20 million per year of taxpayer money on ATM surcharge fees when people go to take out their money. So I'd love to talk to any of you that are interested in partnering around that work, around the food stamp access, CalFresh in California. But maybe that's not the right fit. Maybe you know somebody that would love to come work with us and spend a year in our fellowship program. We nest product teams, 3 people in different environments across the country for a year, and they build digital services together that we then, after that fellowship year, try and spread more broadly. Or maybe you don't have a year to spare. You would be interested in joining one of our brigade programs. So if you want to improve your city or county, again, build digital services together, but not full-time, kind of ad hoc. We have over 105 brigade programs across the country, not just the United States, internationally as well. Actually, our most robust program is Code for Japan. And generally, I would just love to hear from you if you're interested in partnering government, technology, and healthcare. Thanks.
So I was just asking Rebecca to stay here. So my question for Rebecca is just around the concept, around the idea of how do you convince talented technologists to work through local government to make their impact?
Sure, and I think I actually recognize a couple of you who were at an event at 18F the other night. You look familiar, no? I mean, it's an opportunity to leverage skills in engineering, design, product management, knowledge in healthcare, and then leverage against some of the most important problems that our societies are facing today with a partner that has more scale than a lot of other entities could ever begin to hope for. And Code for America is sort of a nice mix because you are working with government, but not for government. So while there's certainly some challenges, there's also a lot of places where we can be a little bit more creative and sort of liberal in our approaches to the problem that we might have if we were internal.
Okay, so our next presenter is George, I might say this wrong, George Tolomiksenko? Close enough? Okay. He's Administrative Director, Health Technology and Engineering Program at University of Southern California. George.
Thank you very much, Jody, and thanks for sticking around. I'm almost tempted to say, and now for something completely different, because what I'm presenting is actually what I would like to think of as an innovative educational program. And when you're innovating education and medication, in medicine rather, medication too, it's a hard thing to do. So what I've done is created a program with my partner, Dr. Terry Sanger, that layers on top of a medical education and also integrates that with people who are studying PhD at the PhD level in engineering. Because what we're looking to do is train engineers and doctors together so that while they're engaged in their graduate studies, they're also working on real projects in the real world. And what I want to say, and my takeaway for this is really it's getting these teams together and teaching them to go through steps that will boost their empathy, level of empathy. This is where it comes from. The need comes from doctors and engineers getting together to solve medical problems and essentially coming from different language perspectives. They need to communicate I'm not going to go through detail by detail, but the key framework we use is design thinking, and that's where we motivate the teams to go out and interact with clinicians in clinical settings, to observe, to participate, to ask questions at a level that ordinarily they wouldn't do. Usually you go, you ask the clinician, what's your need? The clinician will probably tell you their need, and it's going to be wrapped in a solution that's almost impossible to disentangle. That's what we teach our students to do, to get in there and really look for the need that isn't always on the surface. So how do you do that so that you can take really interesting problems back to engineers, as opposed to the doctor wants you to build this, right? I mean, that's not the kind of an interesting problem an engineer will want to tackle. So by getting the engineers in there too, they're also absorbing this kind of skill set. So how do we do it? One of the things I've learned in the 4 years that we've been running the program is I can't predict what the hell's going to happen on a daily basis. So we've had teams, our initial focus has been on medical devices, but teams have gone in the direction of digital health. And one of our teams has done really well in this area and has created a platform that will allow future teams to plug into our own healthcare settings and get projects done more rapidly. So if you look us up, it's D-Health. And they have an outside-facing company called Aikido Labs, which was in Y Combinator, and now we're successful in getting over $3 million of funding. So something to be proud of very early out the gate. But they're continuing to work inside USC because they realize that all the bridges that they've built, based on this empathic connection with C-level people at the healthcare institutions that comprise the growing USC network, are really central to doing this. And part of that, the two ingredients that are listed on this slide, the Stanford Biodesign process. Dr. Sanger came to USC from Stanford, where he was involved at the early stages of the Stanford Biodesign design. And I joined a little bit later to implement this program, where we started with that as a basic ingredient and gave students a longer play time together. So the students have up to 4 years to learn together, to, at the beginning, combine in different teams. So the catch and release projects that are mentioned here allow students to practice all the skills that we teach in the courses within real clinical settings. So neonatal intensive care unit at CHLA, it could be working with orthopedic surgeons and their stated needs, radiology, and what we do is we move from area to area so that over time the students get some familiarity with the kinds of issues that will come up, and then when they fasten on to their own question, the one that they'll as a team possess for 3 years and then bring it to VCs like the previous panel, they'll have had a lot of time to practice it. They've pitched it in front of different internal people, and then they come out well prepared to start companies or to license out through the tech transfer office at USC. So it's an internal sort of process that we're building. And then part of this is that there's a lot of iteration, and this is what we teach our teams. You're not going in to prove that your initial idea is correct. You're there to accept the fact that you will iterate, you will pivot, you will abandon ship in some circumstances and hop on another one. This is all part of the teaching, and we let them practice that. This I won't talk about because it's more of a theoretical slide, but essentially what I'm saying is, instead, how do you get to the point where when you build a team that the sum of the parts is greater, you find a yield that's much greater than the sum of the parts. And you have to get to this idea of a transdisciplinary team, and part of that is what's been written up as Motivation 2.0. And I'd be interested if you feel like there's a piece of this that you'd like to participate in, to learn more about, or to contribute to, because I bring in outside speakers via Skype, or happy to do that, and thank you for your attention.
So just a really quick question for George is just if you could briefly just discuss a little bit the evidence you see that medical device innovators that they should be developing their empathy.
It really ties in through, I don't know, I was listening through biased ears yesterday and today, and all the people who came up and talked about how we really have to focus on the process, or in the example, and this is a direct quote, if an engineer comes with a device to a doctor and thinks it's going to work, it ain't going to work, right? Even if the device probably solves a real need. It has to be co-built, and that's essentially what we're trying to do is, that's an assumption that has been proven over and over again, that you have to get to that point. Yeah, that's it. More time.
Okay, while he's setting up, I'll just introduce Steve Kim. He is co-founder at Voluware, and he'll be doing a brief demo. And just to make note, in the presentation, he's stepping in for Marty Stazak, but they are co-founders and they work together, so we've got a great representative here.
Thank you very much. Good afternoon. Once again, my name is Steve Kim. I am a co-founder of a startup company called Voluware. I also happen to be a practicing pediatric urologist down at the Children's Hospital of Los Angeles. And I have a goal in medicine, which has nothing to do with actually delivering care. My goal is to eliminate the use of paper fax-based administrative workflows in healthcare. I don't know if you're aware of this, but 19 billion paper faxes are exchanged every year in healthcare, and that is very telling about the fact that our current existing technologies and systems really don't communicate in any real meaningful way. Much of what's actually referred between my office and other offices relates to something called patient referrals, where another provider wants to send me a patient to be seen. And accompanying that oftentimes is a litany of paper from the insurance companies called prior authorizations. I have to obtain this before I can actually deliver any services or treat any patients. And this is a definite pain that I've seen in my office, and it's a very manual process now. This one thing called prior authorization, the American Medical Association has actually estimated that the cost of just managing this paper-based process is $23 to $31 billion every year just on the provider side. So you can imagine what sort of costs are being taken away from actual patient care and delivery. And that really angers me. So it's estimated that $12 billion can be saved in the entire system if we actually were able to move this entirely paper-based process over to more electronic prior authorization formats. And so that's kind of what we're working on at Voluware. What we've created is a platform called Valor, and what Valor does is it's a HIPAA-compliant cloud-based software technology, and it's intended to basically allow providers to create, manage, track, as well as to begin to automate both referrals management and prior authorizations. The way we work is that we allow providers to use their existing EMR technologies, and we bridge that with payer web sites where they're available to go ahead and begin automating this abundant paper process and reducing the transaction times, and essentially saving cost and increasing the efficiency of this process. So I'd like to go ahead and give you a little demo of our system. And so the use case here is a primary care office, and so the primary care physician has seen a patient, they've documented in their electronic medical record, and they've also determined that a patient needs to be evaluated by a specialist. And so they have to refer the patient to a specialist, but more importantly, they also have to obtain a prior authorization form to allow them to do so. And so what you're seeing here is the fact that this is our initial workflow that we have. This is what a referral clerk or a financial counselor would do in the office. And what we've been able to design with our system is actually able to input all the data from the electronic medical record electronically via a multitude of different methods, either CCD referrals, ADT feeds, APIs, and direct secure messaging. And so what you see here is all the information that's brought in from that encounter that the physician has written. And so we'll start off with a patient. By the way, this is all fake patient data, so there's nothing real here. Just had to make that disclaimer. And we start off with this referral sheet. And so what this would be is typically this would be all the information from the electronic medical record right now that my office staff would have to print out and scan in and fax over to the insurance company. So what would it draw in is all the relevant clinical information from my encounter, and also the orders to go ahead and refer a patient to a specialist. And so what we'll go through here is for this patient, The referral clerk would very quickly enter in all the pertinent information that you see here. So we'll choose a health plan such as Aetna Healthcare. Their health product would be a Healthy Families product line. We would pick a specialist or specialty type, and we'll just choose an allergy and immunologist at this point. We'll choose a payer. So this is the group that's actually financially responsible for paying for the services, who has to approve the prior authorization. So because I'm a pediatric specialist, we'll pick Children's Primary Medical Group. And we'll choose a specialist that we'd like to send this patient to, as well as someone who's requesting. Now, I don't know how familiar you all are with diagnosis codes. There's something called ICD-9 codes that are very relevant to prior authorizations, as well as how we bill. And so we've developed a system to go ahead and very quickly identify these ICD-9 codes. And for those who may be familiar, ICD-10 is coming up in this country in October, and we're already primed to go ahead and handle that transition very seamlessly. So we'll pick our ICD-9 codes, and then once we do that, we'll go ahead and pick our services that we would like to go ahead and get approved by the insurance company or the payer. And once again, there are filters here that allow people to very quickly identify what services are relevant. So because this is an allergist, we'll go ahead and pick some allergy testing and add all that information into our system. Now, once that's done, there are other notes and documents that may supplement the actual application for the prior authorization that need to be attached. And we can go ahead and do that at any point. One of the critical pieces is something called eligibility. That's actually verify that a patient has insurance at that time that we make that request. And because this is a demo mode, we actually don't have it, but we can actually batch all this information in directly from large payers. And we've done this already with Medi-Cal. And so what I've relatively, actually, let me do one more thing. And we can also create a host of different internal and external workflow documentation pieces that are requested by our providers. Let me go ahead and save this real quickly. And so what you see here is the actual authorization sheet from that payer. This is Children's Physician Medical Group. All this information here, the demographic information, the requesting information, all the ICD-9 codes and CPT codes have all been pre-populated into the system automatically, and we can rapidly shift through 150 different forms. We can attach a cover sheet and send it to the Children's Primary Medical Group. Sorry. And so if we do have a payer that's on paper fax, which a majority of our payers still are, we can very rapidly send it to them via an electronic process. Or if the payer actually has a web portal that we can log into, simply like clicking this button, all that information is auto-logged into their system. We're actually able to batch and obtain the authorization approval and immediately send it out and automate that process altogether. So what ends up happening ultimately is that the approvals come back into our system. And this is a critical piece for physicians to be able to go ahead and send the patient information to the referring specialist, as well as to bill for this. Because the system is looped, this would be a referral, a prior authorization approval process. And once we have that, we can put some basic labels on and very quickly submit this out and push this back into our electronic medical system. And that actually closes the loop between two systems that virtually don't talk to each other at this point. And this is how I plan on replacing paper fax. Every piece of information there had to be handwritten and sent out by fax paper. Our largest primary customer, which is the largest at QHC in San Diego County, has experienced in 6 months 200% increased productivity with their referrals. They've decreased their transaction time from 16 minutes down to 2 minutes per transaction. And they've actually been able to see double the number of patients as a result of this and saving money. And recently has hired on 15 new providers without actually adding a single administrative staff to support this. So that's what we're trying to do. So thank you for your attention.
Okay, so just quickly for Steve, one follow-up question is just, do you actually require the participation of any payers to really be able to deliver the Valor service?
No, actually, we don't really require the participation of any of our business partners or payers. Once again, at Children's Hospital where I work, we have over 300 different payers that we have to interact with, and it's just not feasible to go ahead and do that. What we allow for with our system is to go ahead and automate those processes as we can and really drive productivity without having to integrate in with everybody else. Sorry, is there time for questions? Or?
Oh, no, if we have time at the end, we'll have that.
Okay, thanks.
Okay, we can get questions.
We just have one last presentation, and then if we have a few minutes at the end, we'll take audience questions for the panel.
Thank you all for hanging in there. I'm the last guy between you and the drinks. So, one more session after this? Okay, I don't feel so bad. So I have a vision that will quadruple the number of faxes, paper faxes in there, and that'll create all the deforestation that we need. So anyway, thanks for having me, Pranay and team. It's been a fantastic couple of days. I'm with Connect, which is into chronic care management for diabetics. And I know that you've heard about this many times, but how we're different. There are only three things that I'm going to talk about, what drives Connect's vision of the product and how we service our customers. So the first thing that the whole system is built on is big data, and I'll explain to you what the big data is, and towards the end it'll be very clear. We have basically a way to engage patients through analytics, through big data from different sources. One is payer data, patients' biometric data coming through devices like this. This is a glucometer, which internet-enabled glucometer, which has a little SIM card in it, and as patients measure their glucose readings, directly puts that information into our cloud. So irrespective of whether they have smartphones, access to anywhere, truckers in Arkansas, all of those people, they're able to use this and directly upload their readings at any time during the day directly into our system. The other aspect of our system that drives what we call full stack delivery. So full stack, what I mean by that is we wanted to control the entire experience of the patient, all the way from the time they get their prescription about diabetes strips to when they procure the diabetes strips, meters, all the way to measurement and engaging with a health coach that we have. So that's the entire gamut. So we have our own health coaches at staff that engage with the patients on a timely manner and make sure that they are on track measuring their glucose readings. And we ship our meters and strips all the way directly to the home, bypassing the current brick and mortar pharmacies. So what that has done is essentially compress the value chain. A strip that costs less than a few cents to manufacture, by the time it reaches the insurance payment, it costs about $55 to $60 a box. So that amount of brick and mortar, process and friction all along the way, we are being able to remove that and directly ship these to the patient's home. And in addition, for the same amount, same price for strips, we've been able to provide these additional services like patient engagement, a health coach, engagement platform on the cloud, all of that at the same price that an insurance pays currently for strips. So that's how we've basically what I call a full stack delivery. The third aspect that really drives our whole product and philosophy of engaging with our patients is what I call convenience. A lot of this diabetes is about managing your condition long term. And it's changing habits and changing behaviors, which is very hard to do unless there's convenience in place. It's like a remote control from a couch. People won't change their habits. It has to be as easy as pressing that next button or channel button. So that's why everything we do, all the way from shipping the product directly to the doorstep, knowing when the patient has measured, when they've missed the readings, immediately following up with the patient, to entire process of care coordinating with the primary care physician if the prescription is out of date, and to billings, directly to the claims. So all of that, we've said it has to be convenient and efficient, and that's what we've built in our whole ecosystem. And we're a new company. We're and our first few customers just love it. And we've been, we are on track to make revenue about $250K this year, and we're going to experience fantastic growth in the next few years, and we are looking for the next round of funding. So if you have some good contacts, then I'm all for talking to you guys. Otherwise, after the drinks, just we'll hang out. Any questions, please?
So I think just really quickly for Connect, I think the one question, and Raghav sort of touched on it just now, is that it's a pretty crowded space, patient monitoring. So maybe if you could, you sort of open the door for it, but if you could give a little bit of insight in terms of why you think you'll succeed, how you think your business model is going to distinguish yourself from the others.
Yeah, the biggest factor is our business model. Now, we've tried a lot of wellness approaches where we can try to convince insurance or health payers, healthcare providers to pay for something for longer term benefit or savings. But that has been the remote patient monitoring. Monitor, engage, and you'll find savings at the end. But what we've done is being able to look at compressing the value chain here, doing the full stack. So we are not charging insurance companies or self-insured employers anything extra. So when we go pitch to them, say, give your employees to us and we'll engage them with our program. And by the way, it doesn't cost them anything extra. In fact, it's less than what they pay for their strips right now. They're like, I don't get it. So how can you do that? So that's why, and we're seeing the traction, and we will be successful because of that. And we've seen that, and it's kind of exciting to see that come through.
So we actually have a little bit of time, so if, we can definitely take some audience questions for the 4 members that are here. I think David at Seamless had to step out for a meeting, so if anyone have questions for Valor, for Code for America, for George's work at USC, for Connect, this is your chance. You can ask in this venue.
Excellent question, and we are finding that there are comorbidities, and we've and what we have is a way to care coordinate. We're not a medical service company. We are a health coaching company to help patients stay on track of their action plan. And the action plan has different components to it, like the mental health component also. There are comorbidities. And so we just help care coordinate in a way that assists them and keeps them on track. So and through our app, we are able to collect a lot of vital information through very smart surveying questions, as well as collecting data from other sources, so we can appropriately say, well, they're outside the top 1% highly chronic, multi-chronic condition patient, and they are better taken care of in an intensive outpatient program or some other program, and we will care coordinate for them, but not handhold them. But you're right, we are seeing many of these patients. We have real data behind that also.
Any other questions? Okay, I see one over here.
So I have a question regarding to the referral, patient referral. I noticed on your presentation we're saying that you have the cost of prior authorizations is up to about $31 billion. But through the automations, they're going to have a savings of about $12 billion. So what is the rest of that cost? Or what is the difference between $12 billion savings and $31 billion cost?
Yeah, so those figures are slightly different. I think the first figure is from the American Medical Association, and they're really looking just at the provider side costs, and so that means hospitals or physicians. So the $23 to $31 billion estimate is really just what people like myself, in terms of physicians and providers, are spending on the spend itself. Now, the number for the $12 billion in estimated savings actually comes from David Cutler, who's a Harvard health economist, who looked at a paper describing what some of the problems with paper-based workflows are in administrative transactions, and that's through the Center of American Progress. In his paper, in his estimation, if 85% of prior authorizations and referrals were done in an electronic fashion, that the entire system cost, not just on the provider side, but also on the health plan side, could experience a $12 billion annual savings. And so that's a little bit of the discrepancy. I'm not exactly sure if that's what you're referring to, but the cost of really prior authorizations and referrals management it's a ridiculously manual paper process right now. And you have to, all that stuff that I did with that, all those forms, and I actually didn't have a chance to go through all the forms because we're running out of time, but that's an incredibly manual process. I mean, it takes literally, 20 minutes per authorization, and you got to fax it over and over and over again. And so what we've been able to do is to really kind of manage that in an electronic format. And we're leveraging all that information that's in the electronic medical record that we're starting to gain access to. And so my goal is really to cut paper out of the entire equation and really begin to automate that process, and that would be the ultimate goal. I mean, a third of every healthcare dollar, according to Deloitte, is on administrative transactions and waste and inefficiency. And from my perspective as a physician, the thing that angers me the most is that we're spending that much money on administration and rather on patient care. And that's the reason I decided to do this is I got so frustrated and upset with it that I just took it upon myself to figure out ways to save money on that regard and improve efficiency. So I hope that answers your question.
So we have time for one more question. I see someone over here.
Just a quick question around the business model, as well as what's your main, say, point of friction for customer acquisition?
I guess you guys don't have business models quite. Yeah, but, you do. Okay. So, I mean, really the business model is, it's a SaaS license subscription. There's no hardware or client install. And so what we're selling to our customers is really the increase in productivity and the cost savings around that. So what we've experienced at one of our largest customers, which is a large primary care clinic down in San Diego, is what they've been able to do is essentially decrease the number of FTEs that they have to use to support this activity tremendously, and all that cost savings has been now redirected into actual patient care. And we've been willing, a lot of it's a monthly recurring revenue. It's a SaaS-based business because it is a cloud business, and so that's the basis of our business model. So we charge them for not only the base product, which you saw a little bit above. We do a lot of other things like eligibility scraping. We do prior authorizations for medications, and so a lot of those components are in our system. And so what we've ended up doing is becoming, in many ways, we do a lot of the custom work for customers that have all sorts of issues working around paper processes, as well as interfacing with electronic systems that essentially don't integrate together right now. So there's been a lot of upsell that we've been able to do in our model. So.
Okay, so I think that's it for our panel. So how about just another round of applause for our show and tell?